you talked about hospitalizations and stuff. Talk about home care, like, Tamiflu versus it's time to go to the emergency room.
Perfect. So a lot of triaging of patients with the flu is best done at home. So you get a call, or I get a call from a patient, and I can ascertain that, maybe they do or don't have strep throat. Maybe they do or don't have the flu. Maybe they do or they don't have mono. When it comes to communicable health diseases, measles, mumps, rubella, flu, COVID, etc., those are scenarios in which, number one, can you manage that patient at home? For the vast majority of us who have the flu, it is by definition a self-limited illness. So you may get hit hard, but the chances are pretty good that you will survive it. By day 4 of the illness, you're already on the mend. So if somebody calls me and they're 25 and they're healthy and they're having muscle aches and nasal congestion and a high fever, it sounds like flu. Do I need them to come on in? Probably not. If I ask them, are you having any problems breathing? Are you bringing up substantial phlegm? Are you having any significant neck stiffness? What I'm asking is, are you potentially having the secondary complications of flu? For individuals that have take, for example, underlying lung disease. At the VA that I work, the average age in general is 72. A significant percentage of our patients have chronic lung and chronic heart disease. They are, by definition, the medical folks that you kind of want to watch a little bit more closely. The same thing applied to an individual who has COVID, who has multiple comorbidities versus a young individual. That's somebody in whom I need to pay closer attention to. So an individual who has significant heart or lung disease, if I'm talking to them at home and they say, I'm short of breath, or I'm wheezy, or when I'm walking up the stairs now, I'm feeling it much more than usual, that's an individual in whom diagnosing them with accuracy is better than having them stay at home. That's somebody in whom I may want to come on in. Can that person be triaged where they get Tamiflu based solely on the story? Absolutely. Oseltamivir, which is Tamiflu, is relatively well tolerated. It's best to have that medication prescribed within 48 hours because of the way it works. If you started after 48 hours, it really doesn't have as much bang for the buck. Same thing goes for Paxlovid with COVID. You have to give it within 5 days. And I keep making COVID analogies because that's been on my mind and a lot of folks. But for Tamiflu, it's within 48 hours. So if you get a call, I've been sick for 3 days, Tamiflu may not work too well, you can still offer it. For patients that find themselves in the emergency room door, and let's say they're in bed 5 and they have a little pulse oximeter and their oxygen saturation is beep, 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 it's kind of dropping a bit, they more than likely may need to be hospitalized. Even if it's been more than 3 to 4 days, they still can benefit from the use of that medication. But the things that we do as doctors is this boring flu, or is this flu that can bite you in the butt? And so the folks that we pay closer attention to are not just extremes of age, but folks in whom having a viral infection that affects the airways can tip them over the edge. I always make the point that if all of us in this room get a common cold, we can continue working. But you take an 80-year-old who has advanced lung disease and they mucus plug, meaning they get secretions into the airway, they may find themselves on a ventilator.
So know yourself, basically. I mean, so if I know myself or Paul, we know we're relatively healthy and, I got aches and pains. I've got a temperature, I'm congested, but I'm having no issues breathing. Then, sending a loved one out to go get Robitussin or something is probably going to do it for me. Yeah. Compared to if I'm somebody with lung disease or something.
Right. Most of the treatments are over-the-counter kind of treatments. We call it supportive care. Supportive care means you kind of get rid of secretions, you get rid of aches and pains, so you feel better. Some of the medications that are used, if you go through the cold and flu aisle, are basically 4 major ingredients, just totally mix and match over and over to the point of exhaustion that you can't tell which one to get. But you're basically using decongestants, expectorants, mucolytics, and Tylenol for pain. So most of that, and it's rest and fluids. So it is in my clinical experience, a boring illness, I always say you always want to be a boring patient in healthcare. When you get interesting, that's interesting for us, but not good for the patient. But the patients that do get interesting are the ones in whom they have a lot of issues. So if an individual who's smack dab in the middle of getting chemotherapy for leukemia has a flu-like illness, they could have flu, but they could also have a variety of other things requiring them to get checked out.
Hey folks, connecting with your benefits is our primary mission, and the SITREP is providing more options than ever.
Subscribe to our free email newsletter, subscribe to our audio podcast channel, or subscribe to our content on YouTube.
For details and links, check out the description below.